Hello and welcome to the webinar on caregiver stress and depression. And I will focus today on dementia caregiving, but we could discuss any other chronic conditions of interest to you. My name is Helen Lavretsky and I'm a geriatric psychiatrist at UCLA. I direct the Late Life Mood, Stress and Wellness Research Program at the Semel Institute for Neuroscience and Human Behavior. I spend a lot of time treating patients with dementia and dealing with caregiver stress. And I also study caregiver stress and depression. And while I'm presenting the material, you could ask questions on Twitter using hashtag UCLAMDChat. So first of all, who are informal dementia caregivers? And that's the term we use for family members who provide an extreme uncompensated care, predominantly in home settings, requiring significant amounts of time, energy, financial investment, requiring performance of tasks that are physically, emotionally, socially, and financially demanding. So it puts a lot of stress on families and caregivers. Currently, there are over 5 million people who have dementia in the United States, and as many family caregivers. But by year 2050, we expect tripling of this number. The majority of caregivers are older, and over 70% are women. About 40% provide care over 5 years. So it puts caregivers under tremendous chronic stress that results in deleterious effects on health, such as higher mortality compared to non-caregivers, about 60% higher. Besides cognitive impairment or memory impairment, forgetting things, there are behavioral symptoms in sufferers of dementia, such as depression, apathy, anxiety, aggression, delusions, disinhibition, and moderate agitation that lead to nursing home placement and increased burden and stress in caregivers. What are the sources of stress? And it's, of course, the duration of the illness. It's over 20 years at this point that patients could live while suffering from dementia. And it's a very challenging period of time for caregivers and families. In case of dementia, grief reaction and depression may occur way before patients' deaths due to deterioration of mental abilities and functioning and the sense of loss of a person they knew. Caregivers and family members knew. So it puts a tremendous impact on the family. It results in significant disruption in the family, changes and switches in roles and responsibilities. Typically, if there are several siblings taking care of their parents, it puts conflict and pressure on one of the closest care providers, who is always blamed for what happens to their parents. So under those circumstances, caregivers really have to reach out to patients' physicians, who may be an invaluable source of information and support. Spouses suffer the most and benefit significantly from a long-term social support. If they end up suffering of depression, treatment of depression could result in remarkable difference for caregivers and their relatives with dementia. Depression associated with or brought on by caregiving is not necessarily eliminated or reduced when patient dies. So it results in bereavement and grief following the death. And there are sex differences or gender differences, as we say, between men caregivers and women caregivers. Typically, men tend to get more depressed after the death of their spouses, while women tend to improve. Changing trends in caregiving, certainly there's an increased number of caregivers and who are not currently employed or are employed during the process of caregiving, and it raises all kinds of issues in the workplace. Increased percentage of male caregivers, long-distance caregiving when children, let's say, living in different cities and they're involved in caregiving at a distance. And as I mentioned, caregiver stress and burden results in really burdensome health effects. And I'll list some of the effects. As far as depression and distress, signs of caregiver stress and depression could be different reactions like denial, social withdrawal, depression, sleeplessness, lack of concentration, anger, anxiety, exhaustion, irritability, and health problems. Signs of depression could include feeling empty or sad, excessive feelings of guilt, loss of pleasure, interest in activities, aches, pains, physical sensations that won't go away, irritability, problems with eating and weight, either gaining or losing, tiredness, lack of energy, and insomnia. Sleep really suffers as a result of stress. Allostatic load is a term that we use to describe the process of our adaptation to chronic stress. We all go through this as we age. So, and that's a way our body adjusts to increased stress in life. And that's by increasing blood pressure, systolic and diastolic blood pressure, developing hypertension, obesity, waist to hip ratio goes up, increased lipid profile, increasing cholesterol levels, increased blood sugar, and hormones like cortisol, norepinephrine, epinephrine, that are stress hormones, go up. And protective substance, DHEAS, is protective from stress. That substance goes down with stress. There are psychological reactions to family adjustment, like denial, when initial response is that nothing is going on, or we can solve and conquer all of the problems. The help for caregivers could include increased information about the disease that can help families plan for the future, understand what's going on, and what to expect. Over-involvement, attempts to compensate for the illness and its impairments. Caregiver may refuse help and feel isolated or doing too much, exerting themselves. The help for caregiver can come from the support system, family members or care providers, in-home health aides. Help caregivers understand that no one person can meet all of the patient's needs, and help caregivers see consequences of over-involvement that could be detrimental to the patient and limit their independence. Another common reaction is anger. Why it's happening to me? Why? What did I do? Why am I involved in this? That's a very toxic reaction that is toxic for caregiver health. Long-standing and interpersonal problems can emerge if they had not been addressed before. A lot of blame and guilt going around. So the help for caregivers is a support group for families and for caregivers, and feelings of empathy from others could overcome this feeling of guilt and anger. And when severe anger is present, probably individual counseling can be of help. Guilt is another common reaction developed from anger, and what if brought by looking back, unresolved feelings of anger and guilt can lead to depression. So the help would be to understand, help from counseling and understanding where these feelings are stemming from. They are normal responses to an extreme stress, and what would be constructive resolution of the stress. Acceptance is a positive reaction in a way, and an adaptive reaction leads to resolution and acceptance of the problems, comes from a full understanding of the disease and its effect on the family, and help from the caregiver, for the caregiver, could come from the support, education, and other resources that can help families move forward. There are interventions that have been tested in research and have been developed that address risk areas, such as, first of all, safety of the caregiver and care recipient, and it comes from the home assessment, what can be done in the home environment to protect caregiver and care recipient, reduction and elimination in risk areas. The second area of concern is self-care for the caregiver, and it's sleep, nutrition, exercise, vaccination. So respite care could be helpful. Health practices, education about the importance of this could be important, leading to improved self-care and quality of life and health. Another area of interventions is support for caregivers coming from local Alzheimer's Association or professional organizations, consumer organizations, support groups, where caregivers can get information and referral sources, family therapy, support, and counseling, leading again to improved stress reduction and improved understanding of the disease course and quality of life. Then depression, distress of the caregiver needs specific intervention, and we start with non-drug intervention, psychological or spiritual interventions, meditation, counseling, psychotherapy, mind-body practices, and when needed in severe cases, we do recommend antidepressant use and seeing a mental health professional. Depression, then disrupted behaviors from the care recipient. Sometimes aggression becomes a problem, and it's now time to address those disruptive behaviors through behavioral interventions and drug therapy for the care recipient to protect them and caregivers. And as I mentioned, mind-body medicine such as yoga, guided imagery, meditation, hypnotherapy, spirituality, tai chi, qigong, art, dance, music therapies, anything that brings joy and the sense of fulfillment, and also the sense that caregivers spend time addressing their own needs are all important. And I spent quite a bit of my time studying these techniques, and I'll present some of the results of the studies. So now, a summary of research. If you're experiencing caregiver stress, you may not be able to provide the best care for your care recipient. And studies have linked caregiving of patients suffering from dementia or other chronic diseases to poor physical and mental health and higher use of psychiatric medications. Support from the family and friends, increased self-confidence and resources, examining what's available in the community and utilizing all of the resources that are available to you will positively influence your health and protect against stress and depression. Family members who are not involved in primary caregiving also experience psychological distress and think about their relatives with dementia a lot. That brings a lot of stress and health effects. So they need to be addressed as well. Children in the household may become confused about what's going on with their relatives with dementia and become embarrassed by the family members with Alzheimer's disease or dementia. Counseling can help families and children work through these emotions and deal with the role change. And now I will describe some of the results of the studies that I've conducted for caregiver depression. The first study was 12-week placebo-controlled escitalopram or Lexapro. It's a well-known antidepressant trial. And our caregivers in this study were quite depressed, so they had clinical depression. And we measured depression, their psychological resilience, the levels of distress, burden, and quality of life. So we studied 31 caregivers, mixed age, midlife to older. And in all of them, increased age was associated with low resilience to stress, increased vascular and medical burden. So that's a cumulative burden of disease, the number of illnesses they have, the number of medications they take, and lower physical functioning. The number of years of caregiving led to increased vascular and medical burden. The more they took care of their relatives, the poorer their health was, and the severity of depression and poor general health. Decreased resilience to stress was associated with chronicity and severity of distress, perceived stress. And that's a graph of response. On the red line is on an antidepressant, Lexapro. So overall, caregivers really improved in the first 2 weeks. So it was a rapid response, and they did really well over time compared to those who were on placebo who did worse. We also measured resilience, burden, and distress, and those who took an antidepressant improved in those areas. Those who took placebo did worse over time. So we did show that those who suffer of clinical depression might benefit from taking an antidepressant that improves depression, sleep, boosts resilience, and eases burden and distress, improves quality of life. And then we were also looking into whether that improves inflammation associated with stress, allostatic load, and also we addressed mind-body techniques in caregivers, because most caregivers who are not severely depressed do prefer behavioral interventions, and meditation or yoga would be much of preference, especially in Los Angeles. So we studied Kirtan Kriya meditation, and it's a 12-minute meditation compared to just relaxation, listening to music, instrumental music without words. We studied 39 stressed caregivers with minor depressive symptoms, just a little bit depressed and chronically stressed, who were randomized to 12 minutes per day meditation, Kirtan Kriya, versus passive listening to instrumental music for 8 weeks. So all they had to do is 12 minutes a day to spend in either meditating or just listening to the music. The instruction for listening to the music: go to a quiet place, close your eyes, and just listen to the music. First of all, most of our caregivers did not have 12 minutes, or so they thought. So it was a new concept. I have 12 minutes to myself a day. We measured distress, depressive symptoms, anxiety, burden, and we measured a lot of biomarkers of inflammation, cytokines, cortisol, catecholamines, and cognitive effects. We also did brain imaging, and I'll show some of the results on PET scan. And we measured telomerase, which is a biomarker for cellular aging, and gene expression. So we have quite a few interesting results here. Kirtan Kriya is an 11-minute chanting exercise in the Kundalini Yoga tradition that people had been using for thousands of years. And this meditation involves repetitive finger motion, and those are called mudras, by tapping each finger at a time. And there's an illustration below that shows you finger moving. And it means, Kirtan means song from Sanskrit. The mantra that we use, Sata Nama, means birth, life, death, and rebirth. And Kriya refers to a specific set of movements and chants in the yogic tradition that have physiological effect on health. And it's been studied before in older adults. At the same time as people are chanting, caregivers are chanting, they're also asked to keep their eyes closed and focused on the point between their brows. And it's a common meditative point used in meditative traditions in Buddhist and yogic Hindu traditions. And they're asked to imagine light coming through the top of their head and exiting at the brow point. So they're doing quite a few things. And it's important to know, because we actually see the effect of this exercise on the brain scan that is, tells us that they're exercising their brains while doing this as well. So this graph shows change in depression scores over time. And those who were in meditation group, the blue line, did a little bit better than those in relaxation, but relaxation was actually pretty powerful. So do know that even if you are not chanting or doing anything special and relaxing, you are helping yourself. Resilience improved, again in parallel, but a little more in the blue group or meditation group compared to relaxation group. And the cognitive effects were pretty dramatic. The meditation group improved in cognition, and it's a general cognitive, kind of global cognitive score, but we also had more detailed cognitive abilities, and the relaxation group worsened. Telomerase activity, as I said, it's a biomarker for cellular aging. So the graphs for this also, meditation improved and relaxation worsened, got a little bit worse over course of the study. And this is also an exciting result. We see change in gene expression with meditation compared to relaxation, and it suppresses bad inflammatory response in the NF-kappa B pathway, and it improves good immune response in protective antiviral pathway. Overall, we saw change in 65 gene expression. So it's quite a profound, from a really brief intervention like this, it's quite a profound physiological effect. And now this is the effect on the brain. And the yellow point or area of the yellow in right inferior frontal area that is responsible for making complex decisions or suppressing negative emotions. This area is responsible for this in the brain. Was different between the groups. So that shows change over time and the difference between the groups. So we saw that improvement in right inferior frontal area. So we were very encouraged by these results for future studies of meditation versus drugs versus behavioral approaches for prevention of depression in caregivers. Memory and brain effects can be of interest. And acceptability was actually improved in ethnic minorities. We had a big influx of African American and Hispanic participants who would never come for drug studies. So that was a big discovery for me. They were very enthusiastic about meditating. So in conclusion, how to help caregivers care for themselves. First of all, you have to take steps to prepare for caring for dementia patients, seek out community resources, and those could be adult daycare, in-home assistance, visiting nurses, inquire at your local library, at the hospital, contact elder care locator, and I have a website on the slide. Register with your local Alzheimer's Association chapter, safe return program for safety of your care recipients, and find local support groups. Again, Alzheimer's Association or similar associations for every disease have support groups in your local areas. Especially in Los Angeles, it's not a problem. Ask for help from family members and friends. Attend to your own health, which is of most importance. Plan ahead for future legal and financial issues. Attend to your own advanced planning in case you might die before your care recipient. And create strategies for handling medical emergencies that do not rely on the individual with dementia. Now, specialists might be of help. I'm a geriatric psychiatrist, and we are responsible for treating mental health problems in addition to cognitive decline, like behavioral management for agitation, psychosis, depression, suicidal behavior, and functional evaluation and long-term care placement. Geriatricians, they are our counterparts, very helpful in managing a mixture of complex medical and behavioral issues, complex drug regimen. Clinical psychologists, advanced practice, psychiatric nurses could provide therapy for caregivers, and social workers could offer counseling and link patients and family caregivers to community resources. Activity and physical therapists could be very, very helpful in organizing activities for the day, and occupational therapists can advise on what's appropriate for patient. So in summary, caring for a loved one with dementia requires help from a variety of sources like patients, physicians, family members, and other caregivers. Be alert to caregiving stress and ask for support. Take time off. It's essential. Even an hour a day, attending to your own health and exercise can help you last longer or can support your health. And poor health can be detrimental to patient care. Counseling and behavioral interventions could be also very, very helpful. And I have a number of organizations that could be a good resource for you to learn about the disease, but also resources and progress in research. And thank you so much. And I'll leave this for you to look at the resource page. And now I am going to answer your questions. I was told once that I should use respite care. What is it, and what does it typically involve for the patient and the caregiver? Basically, it's a short-term placement for, let's say, 3 to 4 weeks, whatever vacation you need to take. And some of the nursing homes or board and cares can arrange for short-term placement like this. They have certified caregivers, professional caregivers, who will take your role for you, and you will take a vacation. It could be your family members, So you would have to arrange between your family members that they would rotate in taking care of your relatives with dementia or any other illnesses. But that's what it involves. How do you suggest I deal with my family members' challenging behaviors without losing my patience and stressing out? Over time, it is really, really, really difficult. So there are several ways of dealing with this. Your family member with behavioral problems has to be seen and followed and treated by a care provider who specializes in managing behaviors. And it's typically a geriatric psychiatrist. It could be geriatrician for non-complex behaviors. So they could help you by reducing their behavior. And it could be behavioral modifications, also explaining to you what triggers those behaviors and working with the triggers. Let's say very often family members don't like bathing or grooming or anything like that. So there are ways of dealing with the situation. You could distract them. You could hire professional aid to help only with those tasks. You could pre-medicate them, let's say half an hour before. That's what we do in a nursing home. We ask to pre-medicate half an hour before something needs to be done to this patient. But if this continues, then it would require chronic care for these behavioral problems. As far as yourself, sometimes family members get annoyed at their caregivers get annoyed at their patients asking the same question over and over again, and they are answering and answering and answering. So distraction could be very helpful. Repeating without stressing about it. So you're like a robot, basically. You're dealing with a 2-year-old, and you use the same tools you would use with a 2-year-old. You use distraction. You point to the bird, or because they don't really remember, and it's not their fault that they're repeating themselves. But also do not put any emotion into your caregiving, or just try to be as neutral as possible, understanding that it's not their fault. Empathy and compassion, imagining reversal of the roles. Yourself in this role also would help you understand the dilemma. But it really, understanding never fully helps from experiencing the emotion and stress. So getting help for yourself could be helpful. And caregiver support group is very informative. If my health as a caregiver is suffering due to the care I provide my demented patient, is there anything the patient's physician can do for me? Typically, it doesn't work like that. I counsel caregivers, but as far as, and I would give referrals, and I would point to the places that could be helpful as far as doing psychotherapy with you or providing, prescribing medications for you. It's probably not appropriate, but your own physician could. Do you recommend specific medications for depression and caregivers? Lexapro, I studied Lexapro, so it's a very nice medication, very easy medication to use. The SSRIs, or selective serotonin reuptake inhibitor drugs, are easy to use. Remeron improves sleep and anxiety in depression in caregivers. But the drugs should be of last resort, really. They have side effects, and not everybody responds. So if you have to use it, use it. But do try other things as well. Exercise is an excellent tool. And meditate, I would refer you to a yoga studio. Spiritual care, I'm very keen on that. I just finished a book on resilience in aging, and it will come out at some point in March, I think. But there are tools you could use. Spirituality is a big issue in this end-of-life care for both patient and caregivers. And if you're open to that, all kinds of spiritual support could be very, very helpful for you and for the family members. I'm beginning to see signs in my mother of memory loss. Are there any recommendations you have to start preparing myself and the family for her possible decline? First of all, get her tested. because those who are 40-year-old and over in Los Angeles will complain of memory loss at some point, especially in traffic. We're all multitasking, we're all stressed out, and that reduces our attention and memory. So the signs of memory loss are very common. They may not be symptomatic of Alzheimer's disease or dementia. So get her tested if you're concerned. Neuropsychologists are the ones who are responsible for testing. Geriatricians and geriatric psychiatrists or neurologists can provide screening testing, but a more detailed testing would be provided by a neuropsychologist. At UCLA, certainly we have excellent geriatric neuropsychologist service. There are other behavioral symptoms that could look like dementia or losing memory, like depression. So we usually sort through different issues. Medications can have this effect. Sometimes, especially older women take medications that decrease their memory, and it's for incontinence or many other medications. Tylenol PM can decrease your memory. So that's what we do as physicians, geriatricians, and geriatric psychiatrists. We go through a set of medications that may impact the memory. Otherwise, I put everybody who's concerned and feels like they need some help on fish oil, multivitamin and B vitamin supplementation, and exercise, mental and physical, are of utmost importance for maintenance of mental abilities. What do you think is the number one most important thing that caregivers can do for themselves? Understand that it's not a sprint, it's a marathon. So take your time to take care of yourself and understand the illness and limit your expectations to what can be done and ask for help. And in Los Angeles, we're all very fortunate. At UCLA, we have Dementia Care Program, Longevity Center, that are great resources for help for caregivers. How do I know that I need to get help as a caregiver? Well, ask yourself how you feel. Do you sleep? Do you eat? Are you happy? Your own happiness. Sometimes there are positive features to caregiving, and only 50% of caregivers are depressed, so 50% are not depressed. And they find solace in their caregiving and also power. It's an empowering task. Mastering different aspects of caregiving could be rewarding. And trying to enjoy what you can with your relative with dementia or any other illnesses. I really put an emphasis on joy. It's not the disease, and it's not what you lack or you don't have. It's what you have. You have to focus on it. The glass has to be half full at all times. And if you don't have this predisposition or you don't feel that way, try to find a point of view, a perspective that puts you in that situation, because that would result in successful caregiving and satisfaction in your role and enjoying your relatives' lives. When do I know that I need an antidepressant as a caregiver? When you're very depressed, and again, you could see your physician or mental health care professional, or they ask simple questions. Do you feel sad? Do you feel angry? Do you feel anxious? Do you feel depressed? Is your sleep appetite suffering? Is your function suffering? When your function is suffering, that's probably time to try something. When you can't do things that you would like to do. Not because of your caregiving, but just simply you don't have the energy or desire, or you're too sad, you're crying, suicidal thoughts for sure. So those are my recommendations. Okay. Does fish oil really work for memory? Are there any other vitamins or supplements that you can recommend? Well, the studies of fish oil for dementia really don't show much of change, but as far as prevention, there are positive and negative studies of fish oil. There are as many positive studies as there are negative, which is good news, because for most supplements, there are negative studies. So it's a fairly innocuous supplement to take. And I forgot to mention, I'm certified by the American Board of Holistic and Integrative Medicine. So using food supplements and vitamins is one strategy that I prefer to others. And the fish oil, depending on the strengths, would be used in the higher amounts that is usually provided. Typically 2 grams are advised a day, but for those with inflammatory diseases, mood disorders, there's certainly literature that fish oil is helpful for mood disorders, depression, stress. We use 4 to 6 grams a day. So depending on the whole picture and other illnesses involved, we vary the amount of fish oil that we recommend. Vitamin B supplementation I do recommend. There's quite a bit of literature on vitamin B and now increasing literature on vitamin D, and that's for both, for memory, for cognition, and mood, and immune system. So immune system, I repeated it many, many times, plays a huge role in inflammation and aging associated with chronic stress. There are a number of other supplements that others use, like coenzyme Q10. I'm asked quite often about that. Supplements used for sleep, like melatonin or valerian, I typically recommend for those who don't sleep. It's a very slight sedative effect, and I would recommend it before prescribing a sleeping pill. So there's a huge anti-aging community in Los Angeles, and it's usually privately paid for. They use all kinds of foods and supplements that don't have any research support behind it. What are the first steps I can take as a caregiver to get help? How can I get my family more active in the caregiving process for my dad? I think reaching to Alzheimer's Association in the area and attending support groups would be very, very informative for you, because typically caregivers learn from each other, and if you're new to caregiving role, you would learn a lot from more established caregivers who've done it for years and know what's available in the community, know what to expect. Your physician and patient's physician who are treating them for dementia could be of help in terms of recommending resources and how to get help. Family more active. It's always a dilemma, especially at the distance, if they live in different towns. But even if they live nearby, some family members may not be inclined to be involved, and it has to do with past history of the relationships usually. But I deal quite a bit with family feuds around not just caregiving, but financial issues, legal issues. So it's easier to get them involved in finalizing this legal issues around care and end of life. But it's very difficult. They have to be open. They have to understand what's going on with your dad and what's going on with you, and provide some kind of support to you. I frankly don't know your family, so I can't really say much more about that. What is? Oh, it's fine. How does the university hospital feel about the use of feeding tubes in terminal patients with dementia? Well, that's a whole different issue. And in Western medicine, we are trained to prolong a life as long as possible. And the end-of-life decisions are very spiritually based. That's why I emphasize spirituality, where you're coming from and where your relatives, what were their beliefs about end-of-life care. Usually having planned for this would be very helpful for the hospital to have, like advanced directives or power of attorney for decision making. So I would advise to take care of it before dementia hits anybody in vocalizing your wishes or your parents' wishes, and that's how it's usually dealt with. You could have a discussion with a hospital chaplain and about this end-of-life care. I have to tell you that half of the patients' families would insist on prolonging life as long as possible, and half of them would not. So it's really hard to say. You really have to work with your physician, patient's physician, and it's a very individual issue to deal with. And as I said, I'm very much into the end-of-life care and what would be the best. I think this society has problems embracing death as a part of living. And I think the organized medicine now is coming to terms with this because the cost of care is so skyrocketing because of this over-aggressive management of dementia. So, and very frequently it's the family that insists on keeping it going. And it's very expensive. So you have to ask yourself, is it worth it? Who's benefiting from it? Who's it hurting? That's it? Okay. Good. Thank you. Thank you for attending the seminar, and let us know what you think. I think there's a mechanism to do so. And good luck.